evening, everyone. I'll just take a couple more minutes before we get started, but thank you for joining us. And we'll just wait a couple more minutes and then we'll get started.
I think we're probably good to go, Claire.
Okay. Good evening, everyone, and welcome to the Northwestern Melbourne Primary Health Network session on residential aged care, new temporary MBS, mental health and allied health service items. My name is Claire and I work in the workforce development team at the PHN and will be facilitating the session today along with Rivka. Now, before we begin, I'd like to make an acknowledgement of country. The Northwestern Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters, culture, and would like to pay our respects to the elders past, present, and emerging. Here is a brief outline of the agenda for this evening. We will hear from a range of speakers about the new MBS items, and there will be time for questions at the end. And just for the next slide, Rivka, there's also some brief housekeeping. Participants are muted for the session, but if you would like to take part in the discussion or ask a question using your microphone, if you could use your raised hand function, we'll be able to unmute you and bring you into the discussion. Please note that the session is recorded and that all questions and chat will be kept anonymous for your privacy. I do also ask that if the name in the Zoom meeting is different to the one that you registered with, if you could please send a message in Zoom to Northwestern Melbourne Primary Health Network Education or an email to education@nwmphn.org.au. This is just to ensure that we can mark your attendance and provide certificates and points tonight. Now I'd like to introduce our speakers and panelists for today. We do have a few with us and we're very excited to hear from all of you in the session. So I'd like to introduce Rivka and Kim. So Rivka's from Medical Business Services and Kim is from MediCoach. Both presenters have extensive experience and knowledge in this area and we're very excited to hear from you today. In addition, our panelists also have first-hand experience in this area and each in a different part. So we'll hear from the different perspectives of each speaker, and especially in that panel discussion led by Rivka and Kim. So we have Dr. Jessie, Dr. Jacques and Tori. So thank you all and welcome today. Lastly, I'd also like to introduce Eleanor, who has just joined us this evening. She's a lead for the older adults and will be presenting on the PHN services. So now I'll hand over to Rivka and Kim, and thank you again for all being here tonight.
Well, thank you all for joining us. We've only got a small cohort this evening, and we're certainly cognizant that everyone has a lot on their plates at the moment, and so we're very grateful that you're giving us a bit of your precious time in the evening to have a listen to some of the new MBS items and services available for residential aged care services. It's an absolute delight. I'm saying hello from Judja Wurrung country here in the Macedon Ranges, so I'm not too far from your territories, and I guess we're sort of coming from some disparate areas, some close and some far, and I might just quickly do the quick introduction. Kim, would you like to just come and say a quick hello as well?
Yeah. Hi, everyone. My name's Kim Pointer and I'm from Birrabri country. So up in the healthy North Coast area, Port Macquarie is the home turf that I play from. My background is as a registered nurse. So I started off in intensive care and then many moons ago went over into primary care and found my passion, particularly in chronic disease management. I've had a lot to do with residential aged care facilities, with my grandma residing in one for 8 years. She passed away at the tender age of 108. So I feel like I've got a couple of lenses that I'm going to come from tonight in terms of, you know, providing a consumer perspective and a carer perspective as well as a nurse perspective.
And hello, Jessie. We'll say a hearty welcome to our good friend Jessie Zanker, who's kind of been on this RACF journey with us for a couple of months as well. Would you like to introduce yourself too, please?
Of course, Rivka. Thanks for the introduction and welcome to all of our attendees. My name's Jessie. I'm a geriatrician working in both public and private settings. I'm currently in Wurundjeri country, but spend about half my time in Dja Dja Wurrung and Yorta Yorta country. I'm up from Echuca originally. I'm fortunate to work with two of the panelists, Torres and Jacques, in different capacities over the years. In the public sector, I work at Echuca Regional Health, but also Western Health, in both acute and subacute geriatric care. And in the private sector, I work in residential care and out of GP practices, one of which is Jacques de Gru's practice in New Gisborne. I also work at Aboriginal Community Elders Services and do some tutoring at Melbourne Uni and doing a PhD there as well. So I'm very interested in the residential care space. That was one of the reasons I've focused on providing care in that space and joining in these webinars as well. So looking forward to hearing from the other panelists tonight too.
Wonderful. Jacques, welcome to you. You'll need to just turn your microphone on so we can hear you, Jacques. There we are.
Sounds probably a bit better. Thank you, Rivka, for the invitation to share everybody on this panel. Yeah, I'm in private practice in New Gisborne and co-located sort of next to an aged care facility that has recently extended its facility to 90 beds. And because we're next door, we see a lot of the residents there, and personally I have had interest in aged care for many years, and so this coincided all very well. And together with a colleague, we share sort of almost daily visits, well actually daily visits to the nursing home, looking after the residents, and very interested in see how this RACF space has been developing also through COVID and all the extra services that we try to implement. So great to be part of this. Thank you.
Thanks, Jacques. Tori, welcome to you too.
Good evening. Nice to be with you all. I'm an occupational therapist with 17 years clinical experience, mainly working across public healthcare system. At the moment, I'm working as a private occupational therapist in my own business, Enabled Aging, working in the community to assist elderly people to have a better life and enjoy their everyday activities. So looking forward to sharing some knowledge with you tonight.
Yeah, and it's going to be wonderful to sort of really bring that perspective of allied health to the conversation. It's so rare that primary care and allied health really sort of share the table to work out some of the solution pathways and really get that collaborative work happening. So I think it's really wonderful that we've got such a broad panel here tonight. And finally, welcome to you, Eleanor, as well. Would you like to come and say a quick hi as well?
Hi everybody, thank you for coming along this evening. My name's Eleanor, I'm the lead older adults at Northwest Melbourne Primary Health Network. I'm actually also an occupational therapist by background. I've worked in the public sector and in state government in South Australia. I've worked in South Australia, Western Australia, Queensland and now Victoria. But have moved more into this sort of policy kind of space that I'm currently in with the Primary Health Network and service development.
Fantastic, thanks. And you'll certainly be running us through some of the commissioned services that Northwest Melbourne PHN has on offer as well, and that will certainly be really valuable information. My background is pretty much in practice management. Way back, I have a little bit of a clinical background as well, in that I used to be a laboratory scientist in a previous life, but I've spent many years now looking after medical practices, small, medium and large size. And now I look after Medical Business Services, which is my organisation. And like I said, Kim and I have done a lot of collaborative work really over a number of years now, which has been sort of, really terrific. Finally, you guys, you might know me from the Practice Managers Network on Facebook, which is a group that was started in the Macedon Ranges many moons ago and is now a network of over 7,000 members across the globe. So that keeps us all very active and very engaged in what's happening in primary care, really around Australia and around the world as well. But let's kick off. So we've got a fair whack of sort of didactic information for you. Want to highlight that what the information that especially Kim and I will be presenting to you tonight has its basis in a number of pre-recorded segments for which some of that Jessie was involved with as well. And so if we seem like we're sort of running through some of the items, especially the Medicare items, rather quickly, just want you to remember that there are other resources that sit behind this. Northwest Melbourne PHN certainly has access to those recordings, and they're certainly available to everyone who's registered here and everyone across the catchment. So we'd really encourage you, if you haven't already tapped into those, to just reflect back on those recorded segments. There's also a very big mind map, and there's just a very small sort of snapshot on the slide on your screen at the moment to help you really make sense of the services that have been present already, you know, before sort of the COVID changes and the new MBS items that have been introduced. So it's absolutely a bit of a spaghetti work, and we will talk about some of that complexity. And that's really the reason why we want to have a talk with you about that, because there are so many different service opportunities available to residents in aged care facilities, and hopefully you'll walk away from tonight with a better appreciation of how your practice, how your service can interact, and how you can start those conversations with the facilities around you so that we end up with some better health outcomes for the residents. That's really at the core of what this is all about. So let's move it on. I'm going to hand it over to my good buddy Kim to talk us through the what, how and why. Welcome, Kim.
Thanks, Riff. So what are we able to now claim? It's a very exciting, I believe, space that we're now in, and it's a very temporary space, and it comes because of the Royal Commission. So what we can now do is, if a resident has a shared care plan in place, so item number what you know existing as 731, they can access an additional 5 services. So that's exercise physiology, physio, and occupational therapy. So it only can be accessed, we're going to get into the deeper dive of this, so let me assure you, we'll walk you through and hold your hand through this process after the original 5 EPCs have been utilised out of that shared care plan. It also has call-out fees for GPs, OMPs and allied, longer initial assessment consult fees for allied for chronic disease services, longer Indigenous health follow-up services. We are super excited about that one. Mental health, psychiatric assessment management plans and telehealth services. And why is that so? It's in response to the Royal Commission. There's been a significant rate of mental health issues. It's been really quite a challenging time with isolation. Residential aged care residents have had a significant increase of depression. And the most staggering fact for me was 2018 to 2019, half the residential aged care facility residents had a diagnosis of depression. So it's a response to COVID-19 impacts, to physical and mental impacts, such as reduced mobility, deconditioning, so muscle strength loss and falls risk and inactivity, and isolation due to reduced social contact. So then what are we able to do? What are we trying to achieve here? We're always aiming for better health outcomes. So we want to improve quality of life and wellbeing, getting mental stimulation, engagement in activities such as art, music and sensory therapy. We also want to improve physical function. We want to start to do those prevention and early interventions, maintain and improve mobility, strength, balance, endurance, reduce frailty, reduce falls risk and encourage independence. So we want to make sure we're improving cognition through assessment and behavioural strategies. And you'll also see we're doing dementia management, more person-centred care, retaining abilities where possible, alternate strategies, so we are developing skills when there's decline. We also want to reduce agitation and stress through environmental adaptation, mental stimulation, as I said before, reducing hospitalisation, promoting healthy ageing, and reducing the impact of CDM and disability. So I just love that finally, after how many years of that Royal Commission going, you know, in the back end, that we have something as a result, some action, right? So my next port of call is we need to use them. They are temporary, right? So if we don't use them, guess what the federal government will do? They'll take them away. And after such significant work and such dire need, we don't want to see that happen. So Riff, if you can flick it over to the dementia, you can see that now we're starting to bring in more other modalities that we know have had a great impact in dementia care, such as music, art and sensory therapy activities, rather than medication, right? So we know that there's going to be a lot more benefits if we start to utilise what is available to us and how can we start to utilise these to assist our residents in our care. Over to you, Riff.
Yeah, well, look, and isn't that just a whole grab bag of opportunities and also very lofty outcomes? And I guess I probably want to sort of pause here now and just sort of tap into the panel a little bit. To ask, you know, how, especially Jessie and Jacques, how are you experiencing those activities and those ambitions for RACF residents? What's that really looking like on the ground for you guys? Jessie, I might start with you.
Sure, and thank you for the overview there, Kim. And as you said, Rivka, they do sound like lofty goals. And I think it's important to start with a degree of idealism, but be grounded in the reality of the situation. And I think the Royal Commission did lay bare what the reality of the situation is. And I suspect the attendees, I see we've got a number now, are all interested in this space. So we'll each have their own experiences within residential care, not just at a single facility, but at potentially a range of facilities where the services that are offered and that are available to people are highly variable. So I think it's really important to have these goals and something to aspire to, and it's how you can tap into the local resources, use the resources that are available to us through these additional item numbers if we have the systems to support it. And I think that's an important thing to discuss as to how those are employed. One of the points you've got there, the last one, is adapting the environment to facilitate optimal functioning and minimise distress. Now, many of you will recognise that a lot of facilities might be quite dated structures, and the environment's particularly not well set up for people with physical limitations, but also particularly with dementia, and thinking of novel ways of how those can be adapted through sort of different dementia supports is really important too. One of the things that we know, particularly from the Royal Commission, but through experience perhaps of many, is that it's really those behavioural approaches that do help with dementia. As you point out, music, art and sensory therapies, helping particularly with the behaviours that might be associated with dementia that can be distressing for the individual and others. So I think it's really important to have these lofty goals, and I'm looking forward to the conversation as how we can make them more of a reality in a wide, highly variable sort of workplace setting across multiple residential care facilities. And I suspect Tori might have some perspective as well on the environmental aspects to dementia care too.
Yeah, I'm really keen to hear from Tori too. I'll go to you, Tori, before I come to Jacques. What are your perspectives in this space?
I've certainly seen a lot of facilities that I've been to, they're using some really good environmental changes where they might put the resident's name on the door and 3 things that is highly identifying about the resident. And that's quite helpful. Putting photos in the room of different family members or activities that they used to enjoy is very helpful. There are activity coordinators at these resi care facilities, and they're quite good at running some activities like seated bowls or singing activities, different puzzles, that type of thing. But I can certainly see the benefit of having specialised evidence-based knowledge from OTs and physios to try to tailor these groups a little bit more to get a little bit more out of these sessions. So yeah, I think there's a lot that we can provide in allied health, and through running group sessions we can also identify if clients might be experiencing delirium or some skin issues, and we can then follow that up with the staff there at the residential aged care facilities or their treating doctors. So can have a big impact by having an allied health professional being in those environments, because it can lead to better outcomes for the clients, I feel.
Yeah, great points. What about you, Jacques, from the GP perspective? What are your thoughts?
Yeah, no, I can definitely support all the statements made by others, but from first-hand experience in the nursing home, where I look after the residents, I must also give them compliments that during COVID, especially being creative and finding alternative ways for residents to get through these difficult times, they managed to lock down the facility sometimes because of COVID outbreaks, but at the same time organize with the existing staff that was able to attend, do all these sort of creative arty things. If you go on YouTube, you probably find a nursing home video made with the residents and the staff doing some sort of music imitation, and I don't think it got really viral, but it was definitely a very good, and so families could actually then see what their grandfather or grandmother or parents were doing and were being entertained. So being creative and find alternatives, it was amazing to see that in these difficult times people were able to do that. But moving forward and coming out of this COVID time, all these strategies are well, maybe idealistic at some point, but definitely also there's achievable goals, I think, for sure.
Great points, and I guess it's that variety of approach too, isn't it? That we can think of some really innovative ways to engage and do our crafts just a little bit differently, in that you know, for everyone sort of working independently in their private practices, it might look sort of, you know, quite different, but when you overlay that into that RACF space, we do need to all sort of come together and ideate on how we can bring it all together in a meaningful way for the residents to improve that, and really that's what this is all about too, isn't it? So as we sort of kick on a bit further, just want to give you a very quick overview of what's already in place. So we're going to be talking mostly about the new Medicare items that are available for general practice, for allied health, for mental health. But we just really want to quickly run you through what's kind of already been there for a little while. There are some sort of more recent changes as well. But basically what that comes down to, and we're now mostly talking about the general practice space, is the call out fee. So the flag fall for attending an RACF, that's been around for a little while now, and the item numbers are provided here on the slide. I won't read through all of that. But, you know, the mainstay of services for general practitioners has sort of belonged in that space of attendance items, the short, the standard, the long, prolonged. They've got their own sort of, you know, item number structure around that. You know, and for other medical practitioners, so non-VR GPs, the item numbers are kind of split between, you know, locations. So whether you're an MMM1 or a 2 to 7, there's variation in terms of, you know, the fees applicable there. But, you know, a lot of the work that we're sort of talking about here too, and this will sort of come into that space when we talk about the new item numbers, is the contribution to the multidisciplinary care plan that is provided or created by the residential aged care facility, or the review of such a plan, and that's known as item number 731. That's sort of been that cornerstone of tapping into the allied health through MBS, through the Medicare benefit schedule in times gone past, and that's still certainly around. So the rebate for that, $73.25, is there, and most GPs who participate in that work you know, will be familiar with that particular item number, and that's because the residential aged care facility is compelled to create that care plan. Now, there are some changes coming through to that, so we will sort of talk through the nuance of that. There is a bit of complexity there. We're also talking about the health assessment known as the comprehensive medical assessment. And for the GPs in the room, you'll recognise those item numbers as being exactly the same as the numbers that you would use within your practice for other health assessments, like 45 to 49-year-old health assessments, 75 plus health assessments, and there's a whole raft of them. You know, the diabetes risk assessment, there's a whole raft of the refugee assessments and the like. So there's a whole stack of them, and one eligibility criterion is for the comprehensive medical assessment for residents of aged care facilities. So the item number that you would be choosing really depends on the length of time of that assessment undertaken, and mostly nurses do get involved in collating that information and preparing that assessment as well. Those times can be counted towards the final item number of that particular assessment item group. Then we've got case conferencing. The item numbers there are listed 736 to 743. For GPs, these are also time-based items. And a really, really exciting development here, which has just arrived on the 1st of November, is that finally allied health professionals are able to tap into Medicare rebates for case conferencing as well. So that's pretty hot off the press. They've been fighting for this for a really long time, and now it's there. So what that means is that case conferencing, which is such a wonderful collaborative bit of work, which has been problematic from the allied health perspective up until now, really becomes far more easy to tap into, because allied health professionals are going to be happier to participate in these activities because they're going to get remunerated for them. So that's a little bit of newness in there for you as well. Then we've got the residential medication management reviews, item number 903, all around managing polypharmacy and ensuring compliance and making sure that we've got safety and optimal health outcomes as far as medications is concerned. Then there's a number of after hours services available for general practitioners as well. And last but not least, and there is a little bit of change in this system as well, is the practice incentive program, service incentive program called the Aged Care Access Incentive, has just recently been revamped to basically double the eligibility dollar amount for general practitioners to actually provide these services. So that's also a recent development from the 1st of July this year. There are service limits. So again, you need to really sort of, backtrack into practice incentives program to have a look at the detail there, but it is segregated according to how many services are provided to residential aged care facilities. And it's a tiered approach. So you've got tier 1A, tier 1B, and then tier 2A and tier 2B. And the ultimate, the ultimate payable is up to $10,000 per year per practitioner, and that's essentially double what it was prior to the 1st of July. So again, what that means is that there is now just that bit more of a driver to really enthuse general practitioners to have a go at what's really complex work. And so there is that recognition of it now, and we really just want to make you aware that, other than just the Medicare services and the rebates associated with that there is some further financial incentive to get involved in that. So that's what's been available up to now, and those new changes to the existing programs. But there are a whole raft of new services available as well. And of course, that's kind of what we want to deep dive into here. The GP temporary item numbers are mostly around the contribution to that care plan. So we spoke about the item number 731, which has been there for a really long time. And now we have some new item numbers, and they're listed here, the 93469 and the other item number there for non-vocationally registered GPs, which is very similar to the 731, but there's a little bit of difference, and I'll run you through those differences in just a moment. But another new and exciting and highly overdue item is the new Aboriginal Torres Strait Islander health assessment. That simply wasn't available, which is just absolutely puzzling, of course, but that is there now, and the item numbers are given there as well. It is the equivalent in general practice of an item number 715. In terms of dollar amounts, very, very similar to that. So take note of those item numbers if you are not familiar with them. So in terms of the existing item 731 versus the new multidisciplinary care plan, the item 93469, there are some subtle differences there. So I'll just quickly run you through what those compliance requirements are for the existing item and then the new item. So for the 731, it is that contribution to the care plan to prepare it every 3 months or review it within that 3-month period. So that's kind of been there for a really long time. It's in the attendance section of the Medicare benefits schedule. And one of the restrictions on using that item number is that you cannot co-claim a 731 with an item, an attendance item. And of course, from a process point of view, that's not necessarily how a service realistically runs. So MBS has kind of recognised that that's been a little bit problematic, and that's where the new item number now is different to the item number 731. In terms of the 731, it's not terribly explicit about the documentation requirements. There are some explanatory notes in the MBS, so if you haven't seen those, feel free to tap into that via MBS online. And as I've said before, it really is that contribution by the GP for the care plan that's provided or created by the residential aged care facility. And again, it is that notion that the RACF actually prepares the plan and the GP sort of contributes to it. That isn't always necessarily how it works in reality, where perhaps, GPs have a much larger input into that original care plan in the first place. So that's where some of that difference comes in as well. Now, that item number, the 731, is the new plan or review, or it is also available for any residents just before they are discharged by a hospital. That's the time at which those activities can be undertaken. So the new item number, the 93469, is still a 3-monthly prepare or review process. And the item number descriptor specifies it has to be a face-to-face attendance. So it can't be via telehealth. It can't be done via a telephone call. It needs to be a physical face-to-face attendance by the practitioner. But importantly, there is no co-claiming restriction with an attendance item. So you can certainly claim the 93469 with an attendance item, but if you choose a 731 for a very similar activity, you can't do that co-claiming. There are quite explicit documentation requirements associated with this new item number, and they're listed just in the last little box on this slide. There's also a recognition that the plan may not be originally developed by the residential aged care facility, so certainly the GP can be the instigator of this particular piece of work. So what's required for that? It's the preparation of the part of the care plan and documentation, or preparing an amendment and documenting it. So you'll see this word document reflected at every stage, because there is an absolute requirement to have evidentiary proof of the work that's undertaken, or giving advice to a practitioner who prepares and provides that document, or give advice to a practitioner who reviews that document. So you can see there is a lot of opportunity for different types of interactions, and there is a lot of opportunity sort of for tapping into this new item number. Again, for more detail on all of this, come back to the pre-recorded segments and we'll give you some more information there as well. in terms of the existing mental health services, that was pretty much an empty space as far as Medicare was concerned and RACFs. So it really sort of looked at services covered by aged care funding were not eligible for Medicare. State and territory funding for older persons' mental health services, and that's around complex need addressing that. And like I said before, there were no specific MBS items in that mental health care space. So a lot of that sort of came down to commission services and state and territory funded programs, far more directly controlled by RACFs. And if I'm not mistaken, and Jacques, I'm really keen to hear your feedback on this, is that those services kind of bypass the GP a little bit when it's organised through the RACF, that there can be sort of a sense of not knowing from the GP perspective of what's going on there. Is that a fair statement?
That's a very fair statement, Rivka. Yeah, that's no, it also requires good communication with the aged care facility to find out. But by taking part in this preparing for this webinar, for instance, there was some new discoveries for me. Definitely to see what's available there. Yeah.
Yeah, excellent. Jessie, any comments from you?
I'm just very excited that these services are becoming more known about and are available, because as Kim pointed out in the introduction, the sort of the 50% rate of depression that is estimated in residential care is profound, and we really need to rethink the way we approach this rather than just pharmaceutically. I think that these new item numbers really help us in that regard.
Yeah, so in terms of the new Medicare benefit schedule items, they are pretty much aligned to sort of the better access model that GPs are possibly more familiar with through their sort of in-practice item utilisation. So there is that notion of, you know, skilled versus non-skilled item numbers, depending on whether GPs have undertaken the further mental health skills training or not. The range of item numbers is given on this slide as well, and it sort of sits along that pathway of mental health care plans and reviews and mental health care attendances. And at this point in time, they cover both face-to-face and telehealth to the, well, that was, you know, to June, but that's been extended out a little bit as well. And the tapping into those services, so where mental health services are then referred out through that Medicare system, the referral from the GP or psychiatrist is going to be required in order to tap into especially allied health services that play in that space as well.
Riff, we've got a question.
Yeah.
Does this mean outside psychologists can get involved?
Yes, it does. Yes, it does. And isn't that just, you know, part of the excitement of all of this, that, you know, we do know that obviously, you know, psychologists and psychiatrists, they do work in the RACF space, but when they have been funded through other buckets, it's kind of precluded, you know, other service providers coming into that space. So yes, now that these item numbers are available in residential aged care, what we'd love to see everyone do is to have conversations with your allied health providers to say, look, might you be interested in, you know, providing some services to aged care? I'm sure the RACFs would absolutely welcome those conversations. And I suppose at this point, I'd love to just stop and tap into Eleanor and say, and see, you know, how does the PHN facilitate and interact in that space as well?
Hi, thanks, Rivka. We, I guess, also have funding available for residential aged care facilities. So we have commissioned, separate or prior to the Commonwealth announcing these new mental health MBS items, they had actually announced funding through primary health networks to commission low to moderate intensity mental health services to go into residential care facilities. So we've commissioned a provider to deliver that service across the northwest Melbourne region. It's a free service. I think one of the challenges potentially with traditional mental health professionals is they tend to be office-based, and there's an expectation that the person goes from home to visit the mental health professional at their office or their location of practice, whereas the service that we've commissioned actually delivers face-to-face services in the residential care setting with the residents, and it's a free service for residents as well.
So I guess those services kind of sit in that separate bucket of funding altogether, doesn't it?
Yes,
so,
they do.
And I guess this is where some of that complexity comes in too, to say, well, which bucket are we talking about now, and where does the funding come from? So in terms of, you know, those directly sort of commissioned services, we will go through more detail of that a little bit later too. We've got some more specific information that I know you're keen to present as well, but layered on top of that is now that opportunity to tap into Medicare funded services as well, which doesn't have necessarily all of the restrictions that come along with commission services as well. So I really do see that there is good opportunity for additional services, and that's kind of what we want to see, isn't it? We need more, because it's all kind of been you know, pretty underdone. So so that's, you know, the new mental health MBS items. Again, the pre-recorded segments will give you more information on that. Now we've run you through some of those sort of core items, but what it's made up of is the ability to tap into up to 20 individual focused psychological strategy services, and that can be either via GPs or via psychology services, so through skilled GP or psychologist. The flag fall applies there, and it sort of follows that methodology of, you know, 6 initials and then a review and then an additional 4, etc. And it works on top of that. So there are specific item numbers for the additional 10 services. So the 6, the 4, and then the additional 10, different item numbers for those additional 10. And like I say, it's a complex item number structure. You really need to get your head around that. So again, tap into the pre-recorded segments, and we spend a little bit more time on that.
Hey, Riv, what's the minimum time frame for a mental health care plan?
Oh, I believe it is 12 months. You're really testing my knowledge here now. Yes, I'm getting a few nods.
I agree. It is 12 months.
Yep, 12 months. Yeah, and certainly where mental health care plans are undertaken, there is an expectation that the reviews get done as well. And, you know, sometimes the reviews need to happen sooner, but, you know, there is that sort of interval placement of that. But certainly I know from the GP perspective, often some of the criticism is that, you know, care or the mental health care plans, just like chronic disease management plans at GPMPs, where the plans get created but not necessarily followed up in the way that's going to constitute great care. And certainly Medicare expects, if you're going to do a mental health care plan, that you also review them at regular intervals. That's the expectation, and that's going to set up that platform for.
And another question for you, Riffy, is 93400 to 93411 temporary?
No, I would imagine, well, look, temporary, what's ever permanent in the scheme of things as far as Medicare is concerned, all around. I would imagine that those item numbers are going to have longevity, because that's what the Royal Commission pointed to. That's what they wanted to see. But it's really only been promised to the end of June 2022 at this point in time. So again, that's why we need to start engaging with these item numbers, because if they're not utilised, then there is that impetus for them to be taken away. So, you know, I don't have the crystal ball. I don't know what Medicare is thinking. I don't know where it's going to fit in with the Medicare, you know, the 10-year reform plan and how that's going to impact. But, you know, I'd probably, you know, wager a bet that it will have longevity beyond June. If not, I think that would be a terrible
just
thing.
to clarify that original question about the time period, it's not the frequency across the course of the year. the question was just clarified then as, you know, the time spent on actually creating a mental health care plan in its own right.
So there are different item numbers for the different length of time taken for the mental health care plans. So I believe it's something like, it's got to be minimum 20 minutes. You couldn't possibly do a mental health care plan in less than that, and up to 40 minutes and then over 40 minutes. So it follows exactly the pathway for GP mental health care plans, and they're split between vocationally registered GPs and non-vocationally registered GPs, then the time difference, yeah, and the like. So, yeah, and also the skills training. So you really need to know where you sit as a practitioner to know which item numbers are appropriate for your skill level, for your training, and then how long you take in preparing the plan. Jacques, do you have any further feedback on that?
Yeah, I actually did look into this and created a few mental health plans for the residents. We are fortunate to have a skilled GP in the practice who I could then refer to for those in the focused psychological services. But yeah, resources is always the dilemma with this. So you can have beautiful plans, but then you have to find the people.
This is it, isn't it? And that's where the complexity comes in as well, of course.
And before you move on, can it be billed, as in a mental health care plan, be billed the same day as an attendance item?
I believe they could, but again, you would need to have very clear documentation that they are very separate services that are being provided. So I would say that the recommendation would be, you know, plan your mental health care plans as an attendance and have that the focus of the work that's done. And unless there is something absolutely urgent that can't wait, I would probably look to put that off to another time. And again, I think probably Jacques is the better one to answer that than me, as you know, I'm not someone who actually claims these item numbers. Have you got
Jacques, do you want to add to that? I could see you nodding in agreement.
Yeah, I just not in agreement. That's you always have to think twice when you do these sort of item numbers claiming, but that's appropriate what Rivka just said. If there's a clear other issue that you have to address, and then you have to add that to your claim that's not related to the mental health plan or all that co-claiming, you have to sort of clarify it a bit for Medicare. And then I suppose these things only really come out if you would get audited, but it's good to stick to the rules. Yes.
Yes, of course. So in terms of, you know, mental health and other services, it kind of runs you through some of those other opportunities there. We've sort of spoken about the PHN commission services that play into that space as well. Some of those commission services don't require a mental health care plan to have been drawn up, so it's easier to refer into. It can be done through the RACF, it can be done through family referral and the like, so the barriers are a little bit lower. And certainly, you know, you'd need to talk to the PHN in terms of seeing what's available in that mental health space as far as commissioned services as well. There's also other services external, like Beyond Blue, Head to Health, Head to Help. Those kinds of programs are also available for RACF staff and residents to tap into. So again, it's just kind of picking out what's the best modality for getting the support that an RACF resident requires. So I think I'm going to give my voice a rest, and I might hand it over to Kim to talk us through some of the existing allied health services.
Great, thank you. Fantastic. So we have obviously just had a massive big walk through the mental health services. And I guess I want to pause and see, particularly from Tori's perspective, if she would like to come and join the discussion here with me on what is available and what does she currently utilise in terms of her OT. I can't quite see you there, Tori.
Yep, she's there.
Is she? Hi.
I think with occupational therapy, we mainly focus in residential aged care facilities on optimising function and improving quality of life and helping clients to experience a fuller life at the facility. In OT, a big focus is on falls prevention, early intervention, and things like preventing pressure injuries. But a big part of our interaction is improving socialisation for the clients, which helps to improve their sense of belonging, self-esteem, confidence, and just creating more of that multidisciplinary team approach. I've worked with Western Health for 11 years, and there's such benefits from having that team approach of having a physio, podiatrist, psychologist, OT all working together. I think we all really benefit our clients by bringing that whole sort of client-centered perspective together. So I'm really excited to see that there's going to be more funding in this area. And I think throughout COVID, a lot of OTs who've worked in the public healthcare system, some have needed to move away from that environment and work privately because they have families and they need to be working from home. So it's a big opportunity now for a lot of private OTs to move into this area of working in residential aged care facilities. The one challenge that we have is that my understanding is we're not able to work across multiple facilities. So I think if you're working in one facility, you're sort of designated to that one area. We have to limit the amount of workplaces that we're working across at the moment. But certainly my experience from working in the public healthcare system is that OTs are very good at running group sessions. In the public healthcare system, I've run group sessions around gardening and getting people outside, getting residents outside into the garden and having a raised garden bed, planting herbs. All of that's fantastic for, you know, their sensory environment and creating interactions and relationships between other residents. But there could be other groups like back care education groups that we could run, or a cooking group that we could run. Falls prevention education, looking at people's shoe wear, you know, at the facility and telling them about what kind of shoes help to prevent falls. There's groups like reminiscence groups where we look back at old photos or bring out old objects and then get the residents talking about their upbringing and what careers they had. And I think like there's so much that OT can add into that environment, but it's probably just going to be contacting OTs either privately, or there are some different organisations who have, I think, been successful in winning their bid to deliver these allied health facilities. And one of those groups is called Viva Healthcare. And they have been successful in being able to run these types of groups in residential aged care facilities to provide group therapy. And another organisation is Health Strong, and they provide OT and physio to assist with treatment plans, rehabilitation, falls prevention and pain management in residential aged care facilities. But I think there's a big option of getting some private OTs into the more rural areas. And I myself live in Essendon, but I do work in the Macedon Ranges area. And that would be an area that I may be interested in the future, is coming into one residential aged care facility and providing some of these services on a private basis, but also doing some group sessions. And they probably can go a bit hand in hand, where if you pick up on some areas that a client is, you know, needing a little bit more OT assistance on, you could then maybe see them from a private perspective as well as in that group perspective. So I'd encourage people in residential aged care facilities and GPs or services to maybe contact the allied health associations of physios or OTs and looking who works in their local area and seeing if they might be interested in providing some of these services to residential aged care facilities.
Fantastic, Tori. I mean, that sounds like an incredible value add for the residents in these residential aged care facilities. What we currently have is these services need to be delivered face to face. So again, you just hit on an important point about, rural locations. What allied members do they have currently in existence in those areas? There's the item numbers there listed on the screen, and we all know that they can be 5 that can be delivered over a calendar year. We've got a listing there of, the plethora of different allied, but again, it comes down to what's available in your area. So we had a question on one of our other previous panel sessions, a diabetes person, have we got a diabetes educator, a dietitian, a podiatrist, maybe not. So what do you have available? And also consider what does the actual residential aged care facility have out of a different bucket of money, right? Because what the important point here is, these new additional 5 EPCs that you can access for exercise physiology, physiotherapy and OT can only be utilised once the very first 5 have been utilised. And on the slide you saw they need to be a minimum of 20 minutes in delivery. So one of the complexities is that if someone is having podiatry and that's spaced over the course of the year, then we're going to run out of time, aren't we, to really deliver those additional 5 EPCs. And it's a matter of how do we even keep track of what's being delivered, how many services are being delivered, who are they being delivered by? So how can we make sure we get the communication pathways really humming, so all interdisciplinary team members, Tori, that you mentioned, if we're all working and communicating really clearly with each other, it can have amazing impacts for a resident. But it's one of those little finite things, isn't it, that we need to make sure that we're keeping track of these things and making sure that we're really, if someone does have a residential aged care facility where a podiatrist can be accessed out of a different bucket of money, maybe that's not how we use our EPC allocation, right? We might use our EPC allocation for different services, like you mentioned, those group programs per se. So the new temporary ones that are coming into play, which we're super excited about, they must have a care plan. So that 731, or the new one that Rivka gave you the detail, that there's a little bit of difference there in terms of requirements. Once per year per service type, included in the original, once the original max services have been used, those 5. And again, the item numbers are listed there, and a minimum of 30 minutes. It's again just, fiddling with the time, isn't it? Knowing all the rules that go with it. I can see a riff going.
So those are the initial services. So it's kind of now split, not just in 20-minute services, 5 of those. It's now an initial service, half an hour, and then the subsequent service. So again, more complexity in that.
Yeah. And again, then you have the subsequent services, which are back down to 20 minutes. So you really need to be across, particularly for the likes of you, Tori, on the time limits that I'm going in and utilising, these additional items as well. We do have a telehealth and video item number there, and also a telephone item number there as well. So as I said, maximum, you need to utilise your original allocation of EP services, and that could have been for psychology, it could have been for occupational therapy, it could have been for OT, it could have been for dietetics. But once they're exhausted, those original 5, then we can only use the additional for physio, OT and exercise physiology. If the service is included in the care plan, no new referral is required, and they're only face-to-face services. You got anything to add there, Riff?
Yeah, look, I'm keen, I guess, again, to just sort of tap into Jacques' experience in terms of, the allocation of those visits and the complexity around that. Have you experienced some issues there? This is why there's the big exclamation mark on this particular slide, because of the differentiation between what types of allied health services can be used for those additional 5, makes it just really very complicated in terms of scheduling your services along that year. What's been your experience of that, Jack?
Yes, it has been sort of almost a tradition over recent years that, and actually it happened yesterday I got a message from the reception. The podiatrist phoned, please write 3 new referrals for aged care residents, because that had to be renewed. So the podiatry, I think, is very much has found their carrots in this space, and knows the incentive for them to actively approach GPs to get, or nurses who are involved in these care plans to get their share. So the communication has to shift a little bit, and see if there's other ways to tap into this. Otherwise, it's very difficult. We are fortunate to have an exercise physiologist attending at the clinic, so I got her involved and approached her. I sent her all the MBS criteria involved in this program. We were going to have a look into it, the aged care facility, but it quickly ended up in the bit too hard basket. When I approached her again to see if we could make it work, she was actually on her way to another aged care facility to do exactly that, and do a group session and some individual sessions. So I said, well, it's already in place then. She said, no, the aged care just sort of pays for it. There's no paperwork. She doesn't have meetings. So it was all very easy, and the residents were obviously excited and had some benefit. So streamlining this program and making it all happen definitely needs more communication, and see if you can create it without, I suppose, upsetting the podiatrists that have established their foot in the door.
Yeah, there's always a little bit of turf wars going on, isn't there? And I've just noticed there is another question that just came through with regard to the multidisciplinary care plan, the new item number replacing the current 731, or is it after the initial 5 is used? And no, it's not replacing it. It's kind of sitting side by side. So, you know, from a practitioner point of view, you have the choice to either remain with using the 731 or flip across to the new item number. And so just remember, there's the difference of the documentation requirements. So in some ways it's easier, in some ways it's harder, but it's not you go from one to the other. It's you can kind of pick which is the right element for the right you know, time and space. And I guess you'd also want to think about whether an attendance item is appropriate for the visit that you're providing, because if it is, you'd be using the new item number, because you can't use an attendance item with a 731. So again, I feel like I need to apologise for the complexity, and I certainly didn't dream up this scheme. But you know, you really need to look at the item descriptors for both, and then decide which is the right one to use, keeping in mind that if we don't use the new item numbers, it could well disappear by the time the middle of next year comes along. And then we kind of, you know, go back to a very sort of restricted, very didactic and not flexible type of multidisciplinary care plan or review process. So I would say, if you've got the opportunity, then maybe have a go at the new item numbers and see how you can flexibly work that in with other service provisions as well. So I hope that answers it as fully as possible.
Riff, I've also got another question, and I might throw this one to Jessie. Why is podiatry excluded from the additional 5 sessions? And my assumptions is from the Royal Commission's finding, it was about the deconditioning was the need, and the mental health. But I'm just going to see from Jessie's perspective.
I'm not sure of the rationale. I suspect your interpretations on that are correct, in that, well, we have a pot of money, how can we use it best, and to spread it over a range of services. And I suspect, noting that it could, with podiatry, be utilised all 10 of those item numbers by podiatry, potentially, because they've got a good structure and system in place. regularity in bookings, and most facilities have that. So I suspect it's with the intention of providing what we know as gold standard of geriatric medicine care, which is a multidisciplinary approach. That's a coordinated care across multiple health professionals. We know that works best, and so I think these item numbers are trying to reinforce that. We know it takes a village to raise a child, but it also takes a village to look after an older person, and to provide that best care. So the idea, I suspect, is for that reason, to broaden the scope and allow everyone to support that person in residential care. I don't know if I can answered your question completely there, Kim, but I'm happy to be challenged on that.
And from your perspective, I've got another question that's just come up in the chat. It said, isn't podiatry paid by the facility? And that's what we were talking about before, isn't it? When you are doing your initial 5, you need to have a conversation with the residential aged care facility to find out what buckets and funding are being allocated to, podiatry services, for instance. So you may distribute EPC allocation differently in that case.
Exactly, and that's where that coordination is really important, and having a good open lines of communication with each facility and how those different systems operate. We know from a previous talk we've done together with the physiotherapists that they were paid for privately by the facility, not utilising these MBS numbers. Now, what the funding arrangements were for that, it's not entirely clear to me, but each facility will have a different arrangement, and particularly in facilities where they're more centrally controlled and they're bigger organisations, they might have different resources to draw from, and so the communication with the clinical care coordinator at each facility, I think, is probably the critical element to get the ball rolling in utilising and maximising these numbers.
So it really sort of sits around the awareness and the clarity of, what's available on the ground from the RACF that really practitioners need to be aware of, so that they can be more intentional, I guess, around planning the services and additional services that may be required.
Can I ask maybe Eleanor if there's a role for the PHN commissioned services, because I've never actually come across any of those services in the aged care facilities that I have attended.
Is there a role? Yes, there is a role in the PHN commissioned group therapy service. The Commonwealth put out funding at the beginning of the year in response to the COVID outbreak. However, to deliver a specific evidence-based program that could be delivered by a physiotherapist, an occupational therapist, or an exercise physiologist, but that funding was limited to residential aged care facilities that had been directly impacted, had 2 or more cases of COVID-19 outbreaks as of, I think it was the 23rd of October last year. So there have been facilities since that have been impacted by COVID outbreaks that haven't been able to access that funding, and all residential care facilities were impacted by COVID lockdowns and reductions in activity levels and the isolation that and deterioration that we have seen in residents. So our Northwest Melbourne Primary Health Network is in the process of commissioning a service that will be available to all residential care facilities across our region. We have less funding than the original bucket of funding, of course, but wanting to make that service available to all residential care facilities in the future. I'm not sure whether I answered your question, Jacques, or not.
Yes, I'll watch that space. Thank you.
Indeed.
All right, so look, I guess in terms of the new group therapy services, so that sort of layers on top of the individual services that are available, just again, that awareness that there are services that RACFs are compelled to provide to their residents at no cost. But the new group therapy services, up to 10 per year. The flag fall item for for allied health does apply to those services, and that's around diabetes education, exercise physiology, with an additional 2 group services there, and dietetics. So again, it's a specific bucket of allied health services. It's not across the board, but they are really helpful, and they can really adjunct well to seeing some of those better health outcomes as a result of that. So for each of the allied health specialties that can tap into that, it must be provided via an initial meeting with the RACF to sort of set and discuss the program. And then every client or resident needs to get an individual face-to-face initial assessment service to assess their readiness to engage in group services. And then there is the availability of 2 hours face-to-face per week per participant for up to 26 weeks of therapy in total. Now, these group services are kind of curriculum based, so it's not just a let's just all get together and do something. It's far more determined than that. And again, probably Tori, you may have some further insight into the structure of some of those group services as well. What does that actually look like, and how do those programs actually run in reality? Have you got some comments on that?
Haven't run any group programs in residential aged care facilities, but I think the other organisations like Viva or HealthStrong, they would be the right areas to probably look at exactly how the group is broken up. But I imagine that the services are all, around trying to improve their quality of life and mobility and strength and physical functioning, and reducing the risk of deterioration because of the COVID lockdowns, and trying to prevent, admission into hospital, those type of things. Sorry, I can't provide more.
And that's fine. Certainly the Medicare benefit schedule is quite detailed in its expectation of what those group services look like. So again, I think anyone who's sort of keen to know a little bit more about what might that look like for the different modalities, the information is certainly all available there. And on that note, I would love
something there, Rivka. Sorry, just with the group therapy services, I think a critical element of that is the time frame for which they're offered. So there's some really good data of some pilot studies and some randomized control trials done on older adults with or without dementia. So often in residential care, as you know, around 50% of people in residential care across the board are living with dementia. And often those people might not get access to as many services because it's felt traditionally that they may not benefit from those. So there's some really good data around older people with dementia who engage in a regular group therapy session that's targeted following an individual assessment, that they can have improvements in their MMSE scores. Now, while you say that's a crude measure, it also is associated with reduced falls and other more functional outcomes, but also quality of life measures as well. So that 26-week period, that 6-month period, is actually quite a good inclusion in this item, in this offering, to allow sufficient time to make gains and also to track progress and see if there is meaningful change over that time for that individual. Sorry to cut you off. Back to you, Rivka.
No, I think that's great additional information, and really sort of putting some good context around those programs and what's available. So Eleanor, I might tap you on the shoulder to just come and have a chat to us about some of the PHN commissioned services for RACF residents, and just let me know when you would like to walk me through to the next slide.
Thanks, Rivka. Yes, can I just say very, very quickly that 26-week program is quite prescriptive. It's based on randomised controlled trials, so evidence-based research. It was a program that was developed by a physiotherapist here in Australia. And the program includes a range of activities, including balance exercises, strengthening, resistance, weight-bearing exercises to generally improve people's physical well-being. But we'll talk about that perhaps in a second. So I just wanted to very quickly put together information for you about the different services that North West Melbourne is currently commissioning for residential aged care residents. This is a moving space. We've just been notified that there's some additional funding coming through, so keep a watching brief, I guess. You will see more activity in this space. The first program that I wanted to talk about was just the delivery of low to moderate intensity psychological support services for residents of residential aged care facilities. So this is that parallel program that works sort of hand in glove, I guess, with the additional psychological sessions through MBS. This service delivers individual interventions or small group sessions by qualified mental health professionals, either on a face-to-face basis, by phone or via telehealth. Their small group sessions can include group activities, group therapy, music therapy, art therapy, a range of different activities. It's really targeting residents who are experiencing or at risk of experiencing mental illness. A lot of the residents who've come in are not necessarily people who've been diagnosed with mental illness, but are experiencing grief. They're struggling with the transition into residential aged care facilities, particularly since COVID. The social isolation and lack of contact with family members has been a key issue. So people who are experiencing or at risk of experiencing a mental illness, it excludes residents with severe and complex mental health needs. There are alternative services for people with those issues, and residents with behavioural symptoms of dementia. The service is really not structured to provide advice or services for residents experiencing BPSD. So there are better alternatives such as DBMAS service. The referrals can be made by self-referral, residential aged care staff, the RN, the resident's GP. The provider, Better Place Australia, do ask that the residential aged care facility RN or GP confirm that the resident is at risk and review whether or not delirium is an issue and identify whether or not there is a history of dementia. People aren't excluded from the service if they do have mild to moderate dementia, but it helps the mental health professionals to know. And then the referral and the person's medication chart is emailed directly through to their intake service. The service is free. There's no cost to residential aged care facilities either. It's not intended to be a long-term therapy service, that somebody who's requiring long-term therapy may be better directed elsewhere, but it's certainly an entry point. And what we're finding is that there are certainly residents who haven't previously identified as having any kind of mental illness who are accessing this program and getting real benefits. So I'm hoping that these slides will be available to participants, because I've included links to referral guides and telephone numbers and contact details for people. So perhaps if we can go to the next slide really quickly. The second program is the Allied Health Services in Residential Aged Care Facilities. So that's the COVID Allied Health Package, which at present is being delivered in our region by 5 different provider organisations. So it's that evidence-based small group physical therapy program, the Sunbeam program. And if anyone is interested in the research paper, I can also send that link through so that people can access that. It is time-limited funding. In theory, the funding expires on the 31st of December this year, but we have been able to negotiate, because there were delays in getting the program up and going and the timelines were really, really tight. we have been able to negotiate some extensions of that. So I think we've got services running through to the end of February at this point in time. As I said, it was only for 53 residential aged care facilities within our region, and we have about 150 across our region. So it was limited to those facilities that had experienced 2 or more cases of COVID-19 as of October last year. So residents of residential aged care facilities that aren't eligible to access the program are obviously not able to access the program at present, although we are, as I indicated earlier, trying to commission a service that will be open to all residential care facilities across our region. Again, it's a service that has no cost to residents and no cost for participation for eligible residential aged care facilities. Can we go to the next slide, please? I just wanted to very, very quickly raise your awareness of this particular program, because one of the pieces of feedback that we had last year when we were contacting residential care facilities was that staff were experiencing very high levels of distress, and that not all residential aged care providers actually offer a staff support scheme. So this was a way of trying to put in place some low intensity sort of soft entry to the idea of mental health for residential aged care staff. So it was really looking at equipping people to better manage their own mental health, to build resilience to stress, to cope with trauma and to cope with grief. And as an entry point to stream people through into more intensive clinical services if they need those services. So once again, there are no costs to residential care staff. Staff are able to self-refer, and residential aged care providers are actually able to request the service on behalf of staff. We found this program has had a really significant uptake. We were surprised by just how quickly it has been taken up by staff and providers as well. And then the last slide, I think.
There we go.
Yeah, there we go. Okay, I just wanted to say that we're also delivering services or commissioning services for older people experiencing mental distress in the community, and particularly people who are quite socially isolated. So these are the people who are very vulnerable and who are at risk of entry into residential aged care. So Merry Health are our provider, and the contact details are there for that particular program. There's further information available on the Merry Health website about that particular program, but I thought that that may also be of relevance and of interest to GPs. And really, at the moment, that is our suite of commissioned services, but there is definitely more coming downstream in the next 12 months or so.
Well, look, I guess I've got to say that, you know, for the number of events that we have run across the country for RACF services, it sounds like Northwest Melbourne PHN has really sort of tapped well into those opportunities and really does have that sort of smorgasbord of availability of some of these commissioned services. So I think it's brilliant, because we haven't seen all that much engagement with service commissioning from, you know, from other PHNs. So I think it's absolutely commendable, and I hope that practices and facilities will tap into those opportunities and make really good use of them. Use them while you can, because otherwise they're just not going to last, are they?
Really?
Great.
Yes. Thank you.
So, look, I think, you know, from here on in, we've got a couple of minutes left, and I think it would be really great if we can focus our discussion sort of on the communication bit that sort of sits beneath all of the complexity of what we've talked about here, and might hand it back over to Kim to kind of introduce that conversation around how do we get all of this humming along.
Yeah, thanks so much, Riff. So we really need to have significant people leading this, don't we? We need to have someone from the general practice perspective, whether you do have a nurse that actually can be assistive in this space, you know, making sure that tracking the shared care plan, the EPC allocation, knowing and starting those conversations about what residential aged care facility funded allied health programs are available, and then distributing the EPCs accordingly, but having a care coordinator at the general practice and knowing who the key person is to connect to at the RACF. So we've heard of case managers, and obviously we've heard of care coordinators at RACFs as well on this journey that we've had across different PHNs. And what we know is that we need those two people, particularly having great communication across the whole network of allied and interdisciplinary team members. And one thing we heard predominantly was, where do we write our notes? Because, you know, the GP have notes, particularly in their general practice, in their software system. And then there's a duplication, isn't there, at the residential aged care facility. So how are we going to make sure that we're communicating really clearly together? And what my favourite thing entirely is about case conferencing. We can have a 3D discussion and bringing the key team members together to say, you know, where are we at with this resident? What best supports do we need? Have we used our EPC allocation? You know, bringing on Jessie into the team as well and saying, Jessie, what are your thoughts on what this person needs? And Jacques is the GP and the OT as well. So having someone who's facilitating those discussions and making sure that we're giving the best that we can out of those new temporary items. So I really want to hear from Tori, really, if she's participated in a case conference, and then obviously coming to Jessie and Jacques to hear their perspectives as well on that.
Case conferences a lot, and I think there's huge value by
Come a little closer to your mic.
Yes, just huge value by getting the viewpoints from, you know, OT, physio, the doctors, and the clinical care coordinators and the nurses who are working on site. We all bring something new and a new perspective on the client, and it helps a lot with their care planning to get such a multidisciplinary sort of view of the client.
Great. And what about from you, Jacques?
Yes, we one of the things we started when we were collaborating with the nursing home, and when Jessie actually started visiting our area, and his colleague Katie as well. But we introduced case conferences sort of on a monthly basis, inviting the nurses from the nursing home, the visiting geriatrician. We actually have the pharmacist who does the medication reviews. She's also very keen to be invited and take part, and a very important contributor to the discussions. And now I hear that there's allied health funding, so and Tori is coming to the Western Ranges, so the case conference is getting bigger and bigger. But I think that's a great way of, especially for the residents, to advocate and give optimal care and implement these sort of initiatives that I'm sure are developed with Medicare with best intentions, but then on the ground level you have to make it work. And yeah, case conferences is definitely a way forward. And I must say also, within the practice, we invite all doctors working on days that we have these conferences to participate. And I think that was actually missing in the slide with item numbers. Participating in a case conference, there's also, so doctors listening to this, if you participate, you can also claim for that. So there's a win-win there.
Great. And Jessie, what's your value add to case conferencing?
I think the value add is in all directions. There's lots of assumptions that are made if you're providing care in a silo, in a silo. If you're providing care, you don't get that whole perspective from the facility staff who are with that resident all of the time. So I learn a lot every case conference, but I also learn a lot from the GPs, the allied health staff, and the nurses present, and the pharmacists. So, you know, while I feel I'm a guest at these conferences, I also feel like I walk away with a lot from them as well. So while they do promote and work towards better care for the resident and more holistic care, they're also highly educational. So I think it's a win-win, no-brainer to get these case conferences more regular, more widespread across different facilities. So I encourage all GPs attending to have a think about how they might be able to institute a similar program.
Fantastic.
Wise words. Well, guys, have a look at the time. It is 8 p.m. We have absolutely smashed it in an hour and a half, and I feel like we can continue this conversation for a long time. There is still so much richness to sort of bring to the table, but I'll hand back to Claire from the PHN, and we'll wrap that up for you.
Thank you, Rivka, and thank you everyone for the presentation today. It is a complex space, but by discussing it in this way with different perspectives and drawing from everyone in the different allied health and medical and the PHN really has kind of brought it all together and been very helpful. Just to wrap up the session, I've popped the evaluation survey in the chat. If you have time to fill out, we would very greatly appreciate it. The video has been recorded and will be shared with everyone who is registered, as well as the slides. And just finally, to let everyone know that all our webinars, including this one, will be on the PHN website resource library, which I can send a link out to that as well after the session. But yeah, just to conclude, thank you everyone so much, to the panel, to the attendees and the questions. Really great engagement, and yeah.